see, okay, why aren't pediatricians more interested in this? Medical home is very intuitive for pediatricians. It's something that we do almost instinctively. And so we received a little pot of funding and decided that we wanted to go out and survey the pediatricians and see what the barriers were to medical home implementation across the state, and if there were any that were specific to Tennessee. We also started participating in several medical home pilots that the MCOs were hosting, because we wanted to see, okay, where are these pilots very useful and where are they not? We also started having conversations with the payers to talk with them about being more friendly towards medical home transformation within the practice. And there were several observations that we made, but by far and large, the number one observation that we had with the private practices was fear of decreasing reimbursement. If I restructure my business so that I'm able to see fewer patients, how am I going to be able to make sure that I am able to make ends meet and feed my staff and feed myself? A lot of pediatricians really wanted to do care coordination within the primary care medical home, but it's a very foreign concept. We're used to having case managers and social workers in tertiary care. We're not used to having them in the primary care medical home. So what do you do with that person, and how do you keep them busy in the primary care medical home context? There's poor communication between all the players in the chronic care model. Very few subspecialists and PCPs were talking to each other. The situation is really bad in the mental health arena, and so we realized that that was a big barrier. Difficulties with electronic data management were huge. This was during the time where a lot of the private practices across Tennessee were converting to electronic medical records, and a lot of the vendors had promised functionality that was either not there at all or was so cumbersome to use that it wasn't worth the time to actually use it. Most of the practices were not partaking in strategic planning, and of course most of us, all as physicians, are frustrated by our patients' inability to comply with evidence-based practice. We can give them good care, but are they actually going to do what we ask them to do? So in phase 2 of this project, we actually decided to investigate some of those barriers to see, are they legitimate barriers? They're perceived barriers, but are they legitimate barriers? We came up with some education and technical assistance to help the practices overcome some of those barriers, and we launched the pilot project with 5 practices across the state. Most of these practices, the majority of their patients are covered by Medicaid, but some were in urban Memphis, some were in rural East Tennessee. They were in all sorts of geographic locations. And we developed a menu of services that is still available through TNAP. But really wanted to look at this fear of decreased productivity and reimbursement situation. So we took, in one particular practice, in my practice, we actually took 6 physicians who had been in practice at least 2 years, so they had full patient panels. And we kept 3 of them in standard practice, and 3 of them sectioned off into the care of kids with chronic illness and their siblings exclusively. We redesigned everything about the care of those kids in the chronic illness group. The shortest scheduled 10-place slot was 30 minutes. You could overbook if you needed to, but you could also take an hour if you needed to. We brought in care coordinators. We brought in nurse specialists to help the patients navigate through their system of care. And what we found is that over a 6-month period, the study physicians, I should also say we did very intense coding education with both groups before we did this. But what we found is that over a 6-month period, the study physicians actually saw about a quarter fewer patients than the standard physicians, but their RVUs, and for those of you who don't know what an RVU is, it's a measure of physician work, essentially, that's assigned by Medicaid or Medicare. But their RVUs of the study physicians actually equaled or exceeded those in standard practice. And when we actually looked at the reimbursements that the physicians received, when we looked at Medicaid, the study physicians collected about 18% more receipts per encounter So they had a receipt loss of about 6 to 7%. But when you looked at commercial, study physicians collected nearly 25% more per encounter, which represented a receipt loss of only 1%. Now, this study did not take into account the increased reimbursement of clinic services, the increased use of clinic services by kids with special health care needs, because they're having more labs drawn, they're calling in more, they're using more staff time. But what this showed us is it was in a lot closer reach than we thought it would. But it actually gave us some information to actually go back to the payers with and say, hey, you're not reimbursing well enough for medical home related services. I'm sorry.
By receipt loss, do you mean net loss?
Net loss.
Net loss.
Net loss in comparison with what the standard physicians, because our assumption would be that they would be making the same as the standard physicians. The thing that made this come very close to working was that we were able to use codes that are specific to medical home provision that are not standardly used in pediatric practice. It's very important that you know how to do time-based coding. I've been talking with several people today about the fact that we do have MD-directed care plan oversight and transition codes that are covered. And just as of January 2015, complex condition care coordination done by non-physician personnel is being reimbursed. So those are very important things for you guys to know about. And actually, I believe on February 4th, Janet Smith, our coding educator, is coming up to do some education on that. So I would encourage you to sign up for that session. One of the things we also saw when we went out is that most of these physicians were trying to do everything themselves. All the medical knowledge was within their head. They were trying to do care coordination, trying to manage the practice, trying to do everything. And that's one thing about medical home. You can't provide a medical home in isolation. You have to have community partners, subspecialty partners, and people within your office who share your knowledge base and can help you expedite care. I'm sorry. Am I doing something that's...
I don't think it's you. I think it's the computer.
So we really needed to focus a little more on team-based care and allowing, especially the primary care pediatricians, to let go. Start to educate some of the people in their office to help them do disease management, and to allow those ancillary staff to have more of an impact on the patients. Thanks. And that's where care coordination comes in. Within the confines of the TNAP project, we've stated that anything that pertains to case management, social work, disease management, or patient education for self-management falls under care coordination. This is the AAP definition, a process that facilitates linkage of children and their families with appropriate services and resources in a coordinated effort to achieve good health. Most of the providers really wanted to do this. They weren't very aware of the available resources in their communities. They definitely felt that they didn't have the staff to hire dedicated care coordinators, so we had to figure out a way to integrate care coordination functions and team-based functions into the primary care office setting without hiring new people. And so that's something that we really worked on. And about this time, there was a lot of evidence coming out to support care coordination. When they looked at the 2009 and 10 study on kids with special health care needs, they found that the families of kids with special health care needs who were receiving care coordination predicted lower out-of-pocket costs, fewer financial problems, less ER utilization, fewer missed days of school and work. And what we found through this project is that care coordination really is one of the most pivotal concepts in medical home. But we had to figure out how to do it. So in phase 3 of the project, we actually worked with Children's Special Services, the Department of Health and Family Voices, to develop a curriculum that was launched in April 2014 to actually go into offices and help primary care pediatricians develop care coordination services. And like I said before, we're including your traditional care coordination mindset of exchange of information, but also disease management and case management, social work functions in this. The curriculum was fairly broad. It covered the basic science of quality improvement and the evidence behind care coordination, as well as case management and disease management functions. We talked a lot about team-based management and processes for creating practice workflow to support the evidence base. And I'm showing you these next few slides not to show you the difference that we saw in care coordination activities. So we asked them, all the practices at a minimum, to have a chronic illness registry, to have some sort of established method for providing care plans to the families, to provide a screening for barriers to compliance, and to come up with a plan to help parents overcome barriers to compliance. And so that's what these next 4 slides show. And I'm showing you these not to show you how well they did afterwards, but to show you how little was going on in these 30 practices across Tennessee at baseline. So very few of them had any chronic illness registry or any designation on the chart that the child might have a chronic illness. Very few of them had an established process at baseline for registries or for care plans. There was almost no screening for barriers to care. And very few patients being linked with resources to overcome barriers to care. We also asked all the participants in this pilot to fill out the NCQA patient-centered medical home survey at baseline and after the pilot finished. And what we saw, what we didn't expect. These are the patient-centered medical home step scores. One of those is care coordination and case management, and one of those is disease management. So we expected to see increases in those two, but we actually saw increases across the board in an overall self-reported NCQA PCMH score of 16%. So that taught us that when you're looking at care coordination and you're impacting care coordination services, you're affecting every aspect of the medical home, not just case management. So other observations from that study was that the more dire straits the patients were in, the more the providers perceived the value of the program and were more willing to take it into the future. So those providers who had large percentages of uninsured patients or large percentages of patients who are on Medicaid were much more likely to be actively engaged in the project and continue the activities associated with the project beyond the life of the grant cycle. And this is just a closing slide. Important points when you're thinking about going into practice residence. It's very important that when you get to your practice where you're going to be practicing, that you engage in self-assessment and strategic planning as a practice. I can't overemphasize that because we've gone into several practices where every partner in the practice had a different strategic plan, and then you just scatter your resources and you're not very effective. Train your staff and expect them to function to the highest level of their license. If you've got an RN in your office, you can do disease management training with them, and they can be doing a lot of that for you while you're going on to the next patient. So it's very important to have those high expectations of your staff and give them the tools that they need to be able to function well. In order to know your patients, you have to ask. It is very embarrassing as a parent to not have the resources that you need for your child's well-being. A lot of times they're not going to tell you about food insecurity. They're not going to tell you that they don't have money for rent or utilities. And a lot of times that's going to be the biggest thing that's going to keep them from executing your care path, is that they don't have the basic things they need for life. And so it's very important that you have a method in your practice to actually ask patients about this on a usual everyday basis so that they can share those things with you, and that you've got a plan for when something comes up that could be a barrier. And then finally, I'm not very good at this one, but medical home development is an evolutionary process, so be patient with yourself. It's never perfect. It will never be perfect. And it can take years to make improvements, so be very patient with yourself as you undergo this process. Here's some great resources for you. The TennesseeMedicalHome.com website has a lot of county-specific resources for patients, as well as information on strategic planning for pediatric medical homes. a lot of great forms you can use for documentation and a lot of good information on coding. Pediatricmedicalhome.org and Pediatric Medical Home Improvement are really great resources as well as the NCQA. Any questions?
Any questions, Dr. Bell? I think as physicians, a lot of times we view the healthcare system from our perspective, and we don't really understand it from the patient's perspective. This is a national, the things that you have been presenting are really critical to the future of pediatrics, I think. It's remarkable that, and there's lots of reasons for this, but we designed a healthcare system basically to serve the children that need us the least. The children that need us most, we don't have a healthcare system designed for them. So, if we really want to impact children's health, promote their development, and again, we have financial forces working against us on this. There's lots of things working against us, but the kinds of concepts that you're presenting here, these are the things we really have to embrace. You talked about the medical home, but of course in specialty care, in hospital care, working across the continuum of care, we have to embrace these things. Any other questions that you might have? Dr. Toshenko.
How do you have like 24/7 continuity of these patients? So you have a care coordinator, the office may be able to hire them for a day or two at a time in the week, not necessarily all days. How do you ensure that you have continuity of these patients?
You know, the Blue Cross Blue Shield pilot, medical home pilot, tried to do that. So what they did is they gave a quarter of an FTE to each participating practice and spread a particular FTE out across practices. That doesn't work very well. It doesn't work very well at all because the patients there, they have a need at that particular point in time. If you can't meet it, they're not going to be compliant. And so what we've tried to do is to train actual staff who are within the private office setting who are available all the time but can kind of multitask. That extra quarter of an FTE in the office, so that person who's not really busy every second of the time but might be passionate about helping people, so that the service is available all the time. Now once you get up to around 8 or 10 positions in a practice, you can keep a care coordinator going full time. And with some of the new reimbursement changes, you'll probably be able to recoup enough to keep them going. I actually had a provider in Memphis who hired a nurse practitioner to do care coordination and patient education full time. That's all she does, and they break even with her every year. So.
When you say 8 to 10 physicians, I guess it depends on the mix of the patients in the practice.
Right,
so,
right.
Like our practice, we have probably a disproportionate number of more medically complex patients, so I'm hopeful that we could sustain a care coordinator with 3 or 4 physicians.
Oh yes,
or something.
you probably could. You probably could, especially in the academic centers or in centers like ours. We kept it going with just 3 FTEs. We kept 1.5 busy full time. But also we had lots of other kids who were not chronically ill who had high psychosocial morbidity. So it really does not work well unless there's somebody in the office who is trained to do it full time.
And then in the EHR world,
Yes.
do you have any plan of cares like models that are developed in EHR already that are accessible? Or?
Yes, so we have several paper-based forms on here. And what we've done, those are not copywritten, so you can take those and actually program them into your EHR in template form. And then we're also working with Dr. Thomas Cheatham with the Disability Advocacy and Coalition. I'm blanking on the name. The Disability Center, as a part of the Vanderbilt Kennedy Center, he actually worked with adults with intellectual disabilities up in Toronto and has come up with several web-based tools that you can use for specific disease management. We also have templates for 17 diseases for which the AAP has anticipatory guidance and health maintenance recommendations. And we have those in paper form. Hey, Dr. DeVoe.
How do office-based care coordinators interface with the more broad coalitions like Tennessee Early Intervention? So you're not doing the same thing, or
So they're your
everybody on the same
go-to.
page?
Right, so they should be the go-to in the office, not the pediatrician. So if my patient's receiving a service, it should go through that office-based care coordinator. And sometimes you need someone who's just handling the referrals for the office, just the paperwork and the clerical aspect of that, along with the care coordinator. But again, it does keep us from having redundant service provision and expense.
I think the care coordinator can help connect the family to those services. But the other thing the care coordinator can do, working with the provider, is if they're getting a service, a specialty service, and they're getting education or they're getting information, then we can help reinforce that. And the care coordinator can also reinforce that, follow up, and be a help to, say, early intervention to make sure they're staying plugged into early intervention or engaging, following the advice of the, just reinforcing the kinds of information that early intervention might be giving them.
And so, for example, we rounded on all of our inpatients. In my practice, we went to Bandy every morning, we would round, and then we would come and see patients. So I always stopped and let the care coordinator know who was in the hospital, what was happening, what their anticipated discharge timeline was, what issues might be there, so that they were working with the hospital case manager to facilitate all of that, so that there was a smooth transition out into the community setting.
One of the things we're planning to do here, and this will take a while, but we're planning to have, a hospital-based care coordinator, and this isn't like the case manager that helps with discharge. This is really someone who's looking across the child's life and helping them with episodes of care and making sure they're not coming back to the hospital in an unplanned fashion and preventing hospitalizations that are unnecessary, but working with the medical home where we'll also have a care coordination team. So there's going to be, we're hoping that over the time we can set up a more robust care coordination infrastructure here between primary care and the hospital. And specialty care, pardon me, I don't want to leave out this one.
That's right, specialty care is important too. So, any other questions?
Great.
Great.
Thank you
Okay,
very
so-
much.